Thank you very much. We've got an incredible crowd here in this beautiful facility. My name is Cameron Lynch. I have the great privilege of serving as the Executive Vice President for the Bipartisan Policy Center, which is one of your hosts here along with the Dole Institute. I'm going to talk a little bit more about the BPC in just a few seconds, but to welcome you from the KU perspective, I'd like to introduce Dean Barbara Atkinson, who is the Executive Vice Chancellor of the University of Kansas Medical Center.
Thank you. It's really a pleasure to welcome everybody, the panelists, and everybody who came. This is on behalf of the Chancellor who's here, Dr. Robert Hemingway. We're really thrilled to be hosting this on behalf of all of KU, and including the University of Kansas Medical Center. This event highlights the special nature of the Robert Dole Institute for Politics as the wonderful place where policymakers, thought leaders, and the public can come together to engage in a meaningful and thoughtful civic dialogue about important issues that confront the nation, and this is certainly one of the most important. I want to commend Senator Dole for his vision in establishing this institute and for his work with the Bipartisan Policy Center and Leaders Initiative on the state of American health care. I also want to acknowledge the great work of Bill Lacey and his team for making this event possible. The opportunities and challenges of healthcare have never been greater. During the past generation, with breakthroughs in recombinant DNA, sequencing the human genome, and discovering the potential of stem cells, the life sciences have never been so promising. But they're gathering storms. This year, for instance, the U.S. will spend over $2 trillion on healthcare, twice as much per capita as any other nation. This number is expected to reach $4 trillion by the year 2015, which would represent 20% of our gross domestic product. Yet by most measures of public health, from infant mortality rates to infectious disease to longevity, Americans suffer by comparison to other industrialized democracies. Most of these countries offer universal health insurance, while some 47 million Americans are without coverage. Inequities still exist in our health outcomes, startling disparities that call out for justice. Whites live an average of 5 to 7 years longer than blacks. African Americans have 38% of all AIDS-related deaths in the U.S., despite the fact that they're only 12% of the population. Infant mortality is doubled for blacks. It's even worse for Native Americans, where infant mortality rates tops that of whites by a full 48%. And while the anticipated lifespan of Americans has risen from 61 years in 1933 to over 78 years today, the rising tide of American health is not lifting all boats. With widening gaps in life expectancy emerging based on income, race, sex, education, and geography, in our quest toward a more perfect union, we must act to address this blemish on our nation. This series of forums under the auspice of the Bipartisan Policy Center and Leaders Initiative, which Senator Dole has helped lead with Senators Baker, Daschle, and Mitchell, will, I believe, provide a powerful forum to help shift the dialogue on health care reform. Accessible, affordable, and quality health care for all Americans. It's not a Republican issue. It's not a Democratic issue. It's all American. The issue belongs to us. We each have a role in crafting a solution, and that process starts with informed debate. By learning more about these issues, we can empower ourselves to engage in the discussion and be part of the changes that will be necessary to solve this crisis. And by calling on our elected leaders to work together to address these issues, we are allies with the Bipartisan Policy Center and its leaders. The displays in this very room remind us that when talented leaders work together, great things can happen. Senator Dole's example of legislative leadership is a legacy we can all build upon. Many are willing to discuss what's wrong with our healthcare system, but solutions have been more elusive. There's not going to be a technical fix to this problem. Solutions will be found only if we're willing to adopt a new paradigm into a new set of assumptions about health, individually and collectively. Promising innovation is occurring both within and outside government, and we will hear more about that in today's panel discussions. We need to nurture the seeds of this innovation and not be afraid to engage in bold and creative thinking about how best to use the talent, technology, and tools we have to bring about real progress. We are fortunate in Kansas, from the thoughtful work of the Kansas Health Policy Authority under the leadership of Marcy Nielsen, who you're going to hear from, and her board, that the authority had 21 recommendations for health reform in Kansas. And this represents a great first step in moving us forward, and if implemented, would position our state as a leader in this field. It is my hope that today's discussion will reinforce the need to advance the authority's recommendations. Doctors, healthcare workers, and every single one of us need to be behind this effort in order to make a change happen. I want to thank you all for being here and working to become better informed citizens, and then working to help us make the changes we need. It's my hope that when what we learn here today will help us improve the health of all Kansans. Again, thank you for coming, and welcome to the Dole Center.
Thank you very much. I need to begin with just kind of the traditional promotional announcement to anyone who has cell phones. Please make sure they're on silent or vibrate so that we don't interrupt the panel. Thank you. I'll begin my introductory remarks with an apology. And my apology is for the lack of humor in what I'm about to say. I speak quite a bit on politics, and I'm generally regarded as being somewhat funny. The problem is that I steal all my jokes from the man to my left, and I can't do that because he's here right now. But it's a great pleasure for me to be here. I grew up about 30 miles away in Overland Park, Kansas, and it's wonderful to be back here. Worked for Senator Dole for several years. I'm going to talk to you a little bit about the Bipartisan Policy Center, how we were founded, and what we seek to do. We were founded officially 2 years ago by 4 former Senate Majority Leaders, Senator Dole, Senator Howard Baker, Senator Tom Daschle, and Senator George Mitchell, all 4 of whom were highly regarded as very bipartisan advocates and leaders while they were in the Senate. We are not a think tank in the traditional sense that you would think of a think tank. We consider ourselves more of a do tank, which means we combine the academic quality of institution-level research with actual advocacy. So we do promote our solutions to the Hill and to the administration. We're a 501c3 as well as a 501c4. We have 4 major projects, of which the Leaders Project on American Healthcare are our signature. I'll run through them very quickly for you. The first is called the National Transportation Policy Project, which is led by former Senator Slade Gordon, former Congressman Sherry Boehlert, former Congressman Martin Sabo, and soon-to-be Senator Mark Warner from Virginia. Although we had to, because of legally, we had to take him off. We've replaced him with Dennis Archer, the former mayor of Detroit. We have a national security initiative, which is led by 6 co-chairs, General Jim Jones, who just retired as the Supreme Allied Commander, which is a title I highly recommend if you can get it on your business card. It looks pretty good in the office to say you're the Supreme Allied Commander. General Chuck Wall, who retired as a 4-star from UCOM. 2 former senators, Senator Dan Coates from Indiana and Senator Chuck Robb from Virginia, and 2 academics, Philip Zellico and Ernest May, who were the architects of the 9/11 Commission. Our third project is on energy policy, looking at climate change, looking at energy security, CAFE standards. That's led by Philip Sharp, a former congressman, Bill Riley, the former EPA administrator, and John Holdren, who's an environmental professor at Harvard. So we're an exciting institution. We are thrilled to be doing the forums on our Leaders Project, which is our marquee project that Senator Dole and Chris Jennings will talk to you about in just a few minutes. Before I introduce Senator Dole, I figured I didn't need to do a traditional biography because probably everyone in this room knows him either personally or... so I thought I'd tell a little bit of a story from my time when I worked with Senator Dole, and unlike 99% of the stories, this one is not particularly funny, but it actually has to do with Kansas and with healthcare, so if you'll indulge me for just a second. About 2 years before I came to work for Senator Dole, I was diagnosed with type 1 diabetes in the prime of my youth, which was a shock to me, and many of you know who are healthcare professionals, it's a very cumbersome and it's a very difficult disease that requires constant injections and constant pricking of your fingers and blood taking, and it's just it hit me very hard. And I had been dealing with it for about 3 years, and although it was not a fatal disease, it's one that's very difficult to manage. And I was on a plane back from somewhere with Senator Dole. I've always found that being on the plane with Senator Dole is the best time to talk to him, namely because it's just you two and he has to wake up at some point. And so I got the courage up to ask Senator Dole what it was like to have endured so much more pain and injury and suffering and to come through it on the side, and how he dealt with it mentally. And I was afraid of the response I was going to get, frankly. I was either expecting a 30-minute soliloquy or for him to just tell me to go get some coffee. But I'll never forget ever in my life the 5 words he said to me. He said, "They build us tougher in Kansas." That's what he said to me. And I'll always remember that whenever there's any problems in my life, and I think it's a good lesson for us to take, us Kansans. So ladies and gentlemen, proof that they build them tougher in Kansas. My former full-time boss, my current part-time boss, and my forever all-time hero, Senator Bob Dole.
Well, Cameron, thank you very much, and Barbara, thank you for that great introduction, and I'm certainly honored the Chancellor to take time to come over, and I didn't realize there'd be this many people here. This is a hearing on health care, in case you've come to the wrong meeting. But it's a great place, and it is bipartisan. And I've had, endless help from the Chancellor and others at the university to make this place what it should be. And that's bipartisan. In fact, some of my Republican friends said, "When are you going to have a Republican come out here and speak?" I said, "Oh, probably next year." But in any event, it's not about partisan politics, but it's about politics. And we thought this would be a great spot for the health care hearing. It's going to be on the front burner come January. Whether it's President McCain or President Obama, I think the time for health care is next year. And if I were the president, which has a nice ring to it, I would do it very early, because whoever's elected, that so-called honeymoon period, and it doesn't last forever, and sometimes it doesn't last long at all. But I really believe the American people are ready. I believe the medical community providers are ready, and hopefully we can find enough people in each party who are willing to make some hard choices. If we have effective health care reform, it's not going to be universally popular, because we have to make some changes, and because we have to encourage people to accept more personal responsibility in many cases. And I learned back in 1983, working with Senator Moynihan, that bipartisanship, I learned it before then, but this in particular, we were trying to save Social Security, and it was about to go broke. And we had to get something done, so they appointed a commission. And the chairman was Alan Greenspan. And I didn't understand him then either. But, he was the chairman. And we had this great group of Democrats and Republicans, and we tried to come up with how we're going to rescue Social Security, which is in 6 months the payments would be less. In other words, you get a reduction. And we kind of came apart in November of '82. And on January 12th, 1983, Congress reconvened, and it's almost like it happened yesterday. I can still, for some reason, Senator Moynihan and I just sort of gravitated to each other, and almost at the same time, we said we've got to do something about the Commission on Social Security, or it's not going to happen. It's like backing into a buzzsaw, dealing with certain issues, and this is one that's very, very sensitive. But if we didn't do it, it would have been chaos. So Senator Moynihan and I started, the two of us, and then we got three of us, and then four of us, and then five of us. And finally, because we were all willing to give and take a little, it wasn't, when we finished, nobody liked the legislation, which made me believe it was probably pretty sound. I mean, everybody had an opportunity to contribute. We raised the age. We had to raise the tax a little. We did some other things. But the checks have gone out on time ever since it happened in 1983, and it's going to be in good shape at least until the year 2017. Now, I cite that because for a couple of reasons. And we were dealing with Ronald Reagan, who was a conservative icon, and Tip O'Neill was sort of the liberal icon. We had to satisfy them before we could even go to Congress. And it passed the Congress, I think, 3-1, 4-1. But it's an example of what can happen. And as Cameron said, that's why we have this little group called the Bipartisan Panel. George Mitchell's a friend of mine, great leader, a Democrat from Maine. Tom Daschle, our neighbor in South Dakota. Howard Baker, married to Nancy Castlebaum, my colleague, and so was Senator Baker. And myself, four of us who were majority leaders, working with a great staff, and I want to thank the Robert Wood Johnson Foundation for their interest in what we're trying to do, or we wouldn't be here today. They don't have an agenda. It's not a special interest group. They want to find a solution. So the four of us, with a lot of good staff, as I said, got together and said, well, we don't have any votes. We don't have any power. But we do have some credibility. I learned once you leave office, your popularity goes up. People forget why they were mad at you. They say, well, he wasn't so bad after all. And then pretty soon, well, he was pretty good. Kind of good. And depending on how long you live, but, you live long enough, you're pretty good. And having just turned 85, I'm getting way up there on the, anyway. So, Senator Daschle and I worked some on farm legislation and sent it up to Congress. It wasn't spectacular, but, some of the members of Congress liked parts of it. And so this is what we're about today, is how can we, and this hearing is important because we want, the people are going to be affected. We're all going to have a lot of health care in our lives. And I've had a lot. I've had about every ectomy there is. I guess there's one left that I haven't had, but in any event, not many. And I've been a good patient, and I've been a long-time patient. And I thank the wonderful doctors and nurses and therapists and all the others that take care of us. When nobody likes the cost, everybody says it costs too much, we spend too much money, but most people like their doctors. And think of the great advances we're making in health care. My office happens to be in the same building as what they call pharma, the pharmaceutical industry office. They occupy the first 3 floors. And every day I get on there and somebody from pharma, I said, find me a new drug today. And we complain about the cost, but when I look back at the treatment I was getting right after I was wounded in 1945, and what's happening today, in 45, it took 6 weeks to get me from where I was in Italy to Winter General Hospital in Topeka. Today, if you're wounded in Baghdad and you're stable, in stable condition, you'll be in Walter Reed Hospital in 3 days. And we owe that to the advance in technology and the commitment of the young men and women and our friends and our neighbors who choose that as their profession. And having worked for several months with Secretary Shalala, who was President Clinton's health and advisor, ran the health HHS department, one of the biggest departments in D.C. She was my co-chair, and we took a look at health care in the VA and Army and Navy and other DOD, Department of Defense hospitals. And there were a lot of bad stories. You read them. You read about Building 18, which is part of Walter Reed. It's not on the campus, but it used to be an old motel. And I've been there because my sister had a son who had a brain tumor, and she stayed in that motel. Now, he didn't make it because of the severity of it, but it was a motel and never should have been used. It was just too bad. But the hospital itself, Walter Reed, we went around and interviewed patients. We interviewed everybody. We tried to do it when there weren't any doctors around that might intimidate somebody. And we, in a bipartisan commission with 9 members and 5 of us disabled, it was our conclusion that the health care was great. So we want to do the same, or try to do the same, in the private sector. Senator Daschle's already had a hearing in the Washington, D.C. area. Senator Mitchell's going to have a hearing in Maine. Senator Baker's going to have a hearing next month somewhere in Tennessee, and then we're going to try to have a hearing in California, some urban area, and in New York City. So we'll have a pretty good cross-section. But we're interested here not only in the urban areas that we're, Kansas City, this big SMSA, but also out in western Kansas and rural Missouri and other areas. And we have a couple of fine members of our panel here from Goshen, Indiana. And I went out there to make a speech for Tony Snow when he was not able to, and met these wonderful guys. And I said, we've got this little commission. We're going to have a hearing out in Kansas. Why don't you come out? So you're going to hear from them. Well, I would just conclude my remarks, first of all, by thanking the Dole Institute staff and Bill Lacey and all the others for doing all the hard work and getting ready for this hearing. And again, thank all of you for coming. They had some written remarks here, which I just discovered. Like it might have been a nice statement, but yeah, I've got them all here, yeah. No, I'd read them before, Frank, yeah, but I try to shorten it up, probably end up making it longer. But, so what we're, good health care has got to be affordable and it's got to be accessible. If it's out there and you can't afford it, it's not going to do you much good. And if it's not accessible, it's not going to do you much good. Now, Chris Jennings, I want to tell you a little about Chris Jennings. He's going to speak here in a minute. He came along because he's smart. And his father went to KU. That's what really sold me on the whole deal. And there are a lot of his in-laws and Jennings in Kansas. And they're about 50-50, 50% Republican and 50 Democrat. So that's another reason we brought him along. But Chris was President Clinton's top health care policy advisor in the White House. So he knows what the problems are. We don't have a solution. We talked on the way out this morning. There are probably 7 or 8 groups in America, different groups, good people, all trying to find a solution. Both Obama and McCain have offered solutions. I discovered that Hillary Clinton had a health plan that was pretty similar to one that I introduced with Senator Danforth from Missouri and Senator Domenici from New Mexico in 1977. And 30 years later, the Clinton plan is pretty much like the one we talked about then, but there's no support for it. But I think now there is. So Chris is going to, we're lucky to have him. We have him along with Dr. Mark McClellan, who was the former administrator of the Centers for Medicare and Medicaid under President Bush. So we have a Republican and a Democrat. We're trying to keep it bipartisan. Now, some people say, well, we don't, if Democrats, but they don't need Republicans, or Republicans, they don't need Democrats. Now, you can make me take the medicine. That's been my experience in 35 and a half years in Congress, and I've made a lot of mistakes, don't misunderstand me. But I learned along the way that it's good to have people in both parties on board. It just makes common sense. You don't have to give up your principles or your philosophy. Some things you can't agree on. But something that affects every American, something as important as health care, can't be addressed in a partisan way. Because there's going to be what I call shared misery when it's over. It's not going to be popular. You can't reform a system without making changes. It's just not a question of more Band-Aids or more money. And there are hundreds of issues that have to be addressed. So that we hope we're going to pick up a lot of good information today. And I think we've already announced or will announce that if anybody in the audience would like to submit something in writing, some idea or something, some whatever, we'd be happy to accept it and make it a part of the record. And before I sit down, I just wanted to mention a few people. I don't know everybody in the audience, but I understand we have some very high dignitaries. I know one is Janice Lee. Where's Janice? My state senator, right here. Yeah. And is Judge Tahoe here? She's probably putting somebody away. But Dick Morrissey, is Dick here? He's a Director of Health in the Kansas Department of Health and Environment. Is Ron Worley here? State Rep? Yeah, here's Ron right here. Now, a good friend of mine, Judge Sam Crow and his wife Ruthie. Judge Ruthie, get up there. Yeah, Ruthie's a nurse, so Sam and I were law school classmates at Washburn, and he later became a federal judge. We were going to have a little reunion today, but there's not enough left for a reunion, so Sam is here, and so we have a reunion. And where's Don Hill? He's here somewhere. State representative in the 60th district. Jay Mobunsi, tribal council member, Prairie Band, Potawatomi Nation. They're out to, I'm having a little macular problem too. I need to see a doctor. But Shelley Bueller, Shawnee County Commissioner. There's Shelley. Yeah, thank you for coming. John Jackson, Senior Vice President, Chief Administrative Officer of the University of Kansas Hospital, somewhere out there. And Melody Miller. Hey, Melody, thanks for coming. 89th District, Wichita, State Representative. So now it's my privilege to introduce Chris Jennings to you. And again, as I said, as we go through, we hope you can stay part of the day, and obviously you probably have other things to do, and we certainly understand that. But we're going to, the witnesses are going to give us about 10 minutes, and then Chris and I are going to ask some questions, just sort of bring out some things we need to find out about it as we go through the day. Thank you. Chris.
Well, Senator Dole, thank you so much. It's just an honor and privilege to be back here, and this isn't my first time, as the Senator suggests. I guess when you're Bob Dole, though, it is definitely true that there is no place like home. And I guess I want to tell you, I have been really blessed to be able to witness a true statesman in my years in Washington. It's been about 25 years now. And I did serve on the other side as a staff member for 3 senators and a president and a first lady. You always knew when something was real when Senator Dole said, "I'll work with you." And when he did, lots of things happened. And in healthcare, I watched it in the Finance Committee, in his role as the leader. He brought people together, and he got things done like disability legislation, which we're going to hear a little bit about today, and how that has translated to empower real people to go back to work, yet still have health care. For rural health care to ensure not just people have high quality care, but they have access to it. On a range of nutrition issues, really linking not just the idea of people need to eat to not starve, but they need to eat to be able to live healthy lives with high nutritional products. And certainly, in fact, I remember I just had this picture of the Roosevelt memorial with President Clinton signing legislation into law. There was the Worker Incentives Improvement Act, the Ticket to Work Act, and there he was with President Clinton signing a major piece of legislation into law that make huge difference in the lives of people today and into the future. And of course, as you know, he was the co-chair of the President's Commission on Care for America's Returning Wounded Warriors, and that's such a Washington long name that they just call it Dole Shalala, and there you go, then people think it's real. And many recommendations have already been moved ahead as a consequence. I am the co-staff director of the Bipartisan Policy Center, which means mostly that I'm a glorified indentured servant. And I have to say, far more important here is I am the offspring of a 3-generation Kansan family from a place that not even Senator Dole had heard of, Arnold, Kansas, which is, by the way, near. Where is it near? Utica, I think. I know it's 80 miles north of Dodge City. I remember that.
I think I carried on with that.
And my grandpa was a grocer and a farmer, and my mother served as a postmistress in Arnold. And my dad and his brothers, as he said, my dad was a KU grad, and so I had the honor to meet the chancellor today, and he may give me an honorary degree someday in the future. I didn't talk to him about that before, but as the senators are attending together, I asked my mother-in-law last night. She's from Atchison, and she said, "Well, I think we have about 75 Kansas. It's actually about 60-40 Republican Democrat." But she said, "But they all voted for Bob Dole. Didn't matter whether they were Democrat or Republican." I do want to bring greetings from Mark McClellan, who can't be with you. He is the co-staff director. He served President Bush as the Medicare director, as the FDA commissioner, as the President's White House healthcare advisor. He couldn't keep a job as long as I always had the same job with the President Clinton. But he is a great man. He's a physician. He's an economist. He's a doctor who has a real sense of understanding of the system and brings a whole lot to this process. And as experienced as I am a staffer, and that is who I am, a staffer, Mark's of my job is to, and as well as Matt Kennedy and Christian Leary and others, are to really develop recommendations. We are staff. Senator Dole, Senator Mitchell, Senator Daschle, Senator Baker are the principals. They will be making these decisions, and they will not be making them until after the election to avoid the politicization of any process that we have. But in a way, I would like to suggest and deputize you all who are speaking today as official staff. Because what that means is that you are going to be providing information and background and choices and options for these principals to consider going forward. And I do have a request, though, and this will be something that I will enforce. I have a very important job today. As a semi-glorified staffer, my first duty is to enforce a 10-minute time limit on each of you. And if I fail, we won't be able to get to all the speakers and get the information we need, and more importantly, I may no longer be serving for the Bipartisan Policy Center. So after about 8 minutes, I'll tell you, you've got 2 minutes left, and I hope you will honor that, so I do have a job. Let me just conclude with this, that we have huge challenges in the healthcare delivery system that have been well documented and stated so well today. And, numbers don't really get at it. It's a people issue, but it is a cost issue as well. And we do spend over $2 trillion a year in this country on health care, and yet we still don't have the best care yet, and we still leave out 47 million people. Frankly, if you believe the experts, about 1/3 of the expenditures we make today aren't for services that improve value, that improve care. What we're going to be here to talk about, and we're spending a fourth of our budget on health care, a fourth of our federal budget on health care. We will not be able to sustain that going into the future. Right now, the experts say we will be spending $4 trillion in 10 years. We'll have more uninsured, we'll have more cost shifting. Businesses will no longer be able to compete with world markets. But more importantly than that, people will just not have good quality care, and it has huge impacts not just in terms of their health, but their productivity. When people recognize, and they are starting to recognize that there is a huge link between good health care and our economic abilities. When Ben Bernanke, the Fed chair, says that's our first duty, if we want to address this issue, we're going to address the issue of the economy, is to address the issue of health care. Let me tell you, when those two issues get engaged, it maybe become more complicated, but it certainly becomes far more real. And today what we're going to be focusing on is an important element of that, the role of the individuals. Individuals' role, how people can empower individuals to navigate through the healthcare system in a far better way, the role of individuals to take care of themselves, to prevent care, to ensure wellness, what we can do to help them do that, and not just these in urban settings, but in rural settings. And we need to talk about the differences between the two. And what we're here today to learn is what's working, what's not, what can be done better, and we're going to apply that to our lessons learned that we're collecting throughout our forum process. Let me just conclude with, and I'll conclude my statement at the end of this with some optimism. But I think I want to conclude this comment with a challenge. We rarely have an opportunity to do something bigger than ourselves. It's very rare that the moment in time in political world or the environment comes about where we can make a contribution. And probably the most exciting thing that I can tell you out of Washington is that the people who know health care the most, whether they're the physician community, the nurse community, or the patient community, or yes, the health insurance industry or the pharmaceutical industry, they well recognize that our current system is unsustainable. And what's most important to report to you is that they're willing to engage in a serious discussion to reform how we deliver health care, how we finance care, how we access care. And when that happens, when that moment in time comes, you actually have an opportunity to get things done. I know we talk about special interest groups, but those are actually stakeholders who know something about the system, and we're going to have to take advantage of them and work with them to get things done. And I know of no one better than Senator Dole to lead our efforts in that regard. And with that, I'll thank you for allowing me to come back to my transplanted home. Thank you.
Well, I have the honor. Oh, excuse me, Captain. Oh, that's what you're going to do, sir. You had Russell, Kansas on there. Oh, here it is. all set? Okay. Well, I have the honor of introducing the presenters, and I'll do it very briefly, but again, I want to thank them all for taking the time to be here and to give us their views and their ideas and their thoughts. And we have 3 panels, and one panel may be one short because one of our witnesses had a trouble with his back this morning, so he couldn't come to the health care meeting. Oh, they're giving him cortisone and he's coming. Well, that's good. He may not stay long. All right. Well, panel 1 is we've been sort of entitled Empowering Patients to Access and Effective Use High-Value Care. And our first witness is Marcia Nielsen. Many of you probably know Marcia. She's the Executive Director of the Kansas Health Policy Authority in Topeka. And it's an independent branch created by the legislature in 2005. It manages nearly $2.5 billion. That's $2.5 billion in health care purchasing. It oversees the state's Medicaid and state children's health insurance program, in addition to state employees' health benefit plan and a number of other smaller health programs. And her topic's going to be, she's going to discuss, quote, Working Healthy, an initiative in the state's Medicaid program that assists disabled individuals with getting the supportive care they need to re-enter the workforce. You know, we've got 60-some million people with disabilities, and a lot of those serious disabilities. Many of them, most of them want to work, but getting back in the workforce is not easy, so Marcia's going to give us some ideas on that. Now, should I just introduce the entire panel first? Or?
Oh, just let her.
Yeah. Marcia, you're on.
Lest you think they're not serious, this is the first thing they hand me as I walk up to the podium. Good afternoon, Senator Dole and honored guests. It is a thrill to be here. Thank you for including the Health Policy Authority in what is a truly timely event. And it underscores this important need we have in this country for high-quality health care for all. And the way to do that is going to have to be through the bipartisan leadership that clearly Senator Dole has spoken about. The turnout today is fabulous. There are even people standing in the back. And I got to tell you, I knew Senator Dole was popular.
You know Chris Jennings, though.
As a young staffer in the early 1990s, working in the Capitol for a United States senator from a neighboring state, I was one of many who, when they saw Senator Dole walking down to the well, would quickly turn up the volume on my teeny tiny TV so that I could hear whatever clever, witty, funny comments Senator Dole might have. All of a sudden you'd hear a roar of Senator Dole's voice in our office. We liked the jokes best that made fun of some of those other boutique states. And it is truly a thrill to be here having Senator Dole introduce me. I thank him for his leadership on this issue. As some of you may know, and as Dr. Atkinson referenced this morning, the Health Policy Authority has been working for the past 18 months on health reform efforts in our state. Actually, the legislature told us to advance a plan for health reform, and they told us to include stakeholders. But I got to tell you, there wasn't a meeting that looked like this. And next time I go to the legislature, I'm going to have a little insert that says stakeholder process hosted by Senator Bob Dole, because this is truly fabulous for all of us to be able to be here today. Let me tell you a little bit about the programs that are happening at the Health Policy Authority that Senator Dole has already referenced. And let me put that in the context of high-value health care. As Chris referenced, this issue of giving individuals information to make informed health care decisions is key if we're going to truly empower consumers. But providers also need to be given important, clinical, meaningful information to improve patient care. You've already heard a description of the Health Policy Authority so that you know that we are responsible for purchasing $2.5 billion of health care. We run a number of the state's health care programs. And we also understand that different health needs are different based on any different population. I'm going to talk to you today about the health needs of disabled individuals. And I think most of you are aware that individuals in the United States who've been disabled for more than 2 years qualify for Medicare. And yet Medicare doesn't cover many of the needs that disabled individuals have. The Kansas Medicaid program provides services to these individuals. These programs are managed jointly by the Health Policy Authority and Social and Rehabilitation Services. As I'm imagining most of you understand, for those with high health care costs, and you can see listed here for disabled individuals, they're 4 to 7 times as expensive as other individuals. Having health insurance is critical. Having comprehensive insurance that pays for personal assistance services, mental health, and appropriate specialists is imperative. Most individuals who are disabled apply for Social Security benefits, but most of those individuals never leave Social Security once they start receiving those benefits, and that's largely because they have a fear that they're going to lose their health care. And so, as you heard mentioned this morning, I'd like to talk a little bit about the programs in Kansas that we strongly believe are working today to our benefit, and under Senator Bob Dole's leadership, we have positive news to report on that front. This afternoon, I'm going to tell you briefly about 3 programs we have in Kansas. 2 are programs that help disabled individuals keep their health care and also earn and keep more money without losing health benefits. These are the Working Healthy program and the Work programs in Kansas. The final pilot project I'd like to tell you about is the Demonstration to Maintain Independence. And this is a program that's trying to prevent disability for those individuals who get health care through the Kansas High Risk Pool. So what is the Ticket to Work, that legislation that Senator Dole led in 1999? It's really 2 pieces. The first piece is the ticket, that employment services voucher that helps individuals get access to the workforce. The second piece is health insurance, and this is really the Medicaid buy-in portion of the program. In Kansas, that Medicaid buy-in for disabled workers provides health insurance, full Medicaid coverage, as well as some additional services. Medicare Part B is paid by Medicaid, and there are health insurance premiums that about 70% of the folks in our program actually pay. It's of great benefit to those individuals because they don't have to spend down in order to qualify for Medicaid. They don't have to be under 100% of the federal poverty level in order to receive health care services. And you'll see a number of those benefits that individuals have in terms of being allowed to keep cash assets, having retirement accounts, individual development accounts, etc. The Working Healthy program in Kansas, you'll see some information here. I want to call attention to Dr. Jean Hall, who works here at KU, who is the program evaluator, and Mary Ellen Wright, who is our program director. And you'll see this program has been operating since July of 2002, and we're quite proud that the program has continued to grow. It's leveled off slightly. But what's significant about this program in Kansas is that 70% of the individuals are paying insurance premiums. That's quite different from most of the other states who have these sort of programs. I'd like to provide you with a little bit of demographic data. You'll see here the self-reported level of education. You'll see that the mean, you'll note that almost half have had at least some college courses. The mean age for people who participate in Working Healthy is 47. Most are Caucasian, slightly over half are female, and most are married. In terms of the kinds of disabilities these individuals have that qualify for them for this program, you'll see them listed here, and I know it may be hard for some of you in the back to read. The highest category, and this is the same in Kansas as it is in most other states, are for those individuals who have mental health illness. Second are those individuals with chronic illness or HIV, and finally those with physical disability. In terms of the amount of money that these individuals earn and still keep their health insurance, you'll see the red line is the federal minimum wage. These are 2004 to 2007 numbers. The mean hourly wage for individuals who participate has continued to go up over time, and in 2007 was $7.69. The self-reported hours per week, most of our folks work part-time. And you'll see here that about 32.5% work between 10 and 19 hours, and another 30% work 20 to 29 hours a week. There are a number of studies that are taking a look at this population and how these programs are working. And some of the survey data tells us that, in fact, this program has been very successful from the perspective of the consumers participating. You'll see here just one question on the survey data stating that these individuals' level of independence has increased since they began participating. Over 55% strongly or agree, either strongly agree or agree with that statement. I think one important thing I'd want to draw your attention to, however, is this combined inpatient and outpatient expenses, this per member per month that you see starts to decrease over time. And I think that the reasons for the decline in healthcare costs for working healthy is likely linked to more consistent care that these individuals have. They don't have to spend down in order to get access to these healthcare services, and accordingly, they don't have to wait for healthcare services. I'd like to tell you that Working Healthy is working in Kansas. Successful employment, 90% of Working Healthy are continued to be employed. 77% have been at their job for over a year. 75% are very satisfied with their current employment. 86.1% are getting appropriate health care services and have access to improved quality of life. Where are these folks in Kansas? You'll see they are everywhere in our state. And we have benefit specialists, 7 of them. This too sets Kansas apart. We're the only state that has benefit specialists. And these benefit specialists help those individuals to navigate the benefit system, both federal and state benefits. What is the role of the benefit specialist? They do a whole host of things to help these individuals understand if you work these additional hours, you may or may not lose your food stamps. You may or may not lose your housing subsidy. So very important for these individuals to have a sense of what their total benefit package looks like. In terms of the other 2 programs I'd like to briefly mention this morning, the Demonstration to Maintain Independence in Employment is a brand new program in Kansas starting in April of 2006. The goal is to find out whether or not people who are in our high-risk pool, those are individuals who have chronic illness and difficulty buying health insurance in the individual marketplace, whether or not these individuals will actually be prevented from going on to disability because they have access to good health care. The preliminary data tells us that, in fact, this is exactly what is happening, and we'll have some more data in the next year to share that we think will outline these successes. The other program I'd want to briefly mention for you is the Cash and Counseling Opportunities. This, too, is a new program in Kansas. This actually expands the services of the Working Healthy program for individuals with very severe disabilities. These individuals must be in competitive employment, and I think we too are finding lots of interest in these programs, and the healthcare piece is critical. In terms of the high-value health system for disabled individuals and workers, you can see, as I've listed this morning, there's values for individuals and consumers. The monthly medical costs going down, benefits specialists helping them navigate the system, and the cycle of poverty is broken when these individuals can hold on to their assets. The value for the public and employers is that we can have these individuals in our workforce, contributing to the system, paying taxes. There are some recommendations that we would advance to promote further employment, and I think that recognizing a disability doesn't make someone unemployable. Getting harmony in our federal and state systems is also critical. But I'd like to end by just offering this list, although if this is my opportunity to advance my 21-point health reform recommendations, I'm also happy to do that. I'd like to end the day just by pointing out that this need for bipartisan federal leadership is key. All individuals have to be covered by health insurance. And of course, in our population, as I mentioned, this is critical. We ought to consider new models of governance to oversee public and private programs, the Health Policy Authority being one of those new kinds of governance. I've heard at the federal level, Senator Daschle has some interest in a governance model like this. Promoting this coordination of care that empowers individuals, just like our benefit specialists, is going to be key. And promoting the value through cost-effectiveness analysis and evidence-based medicine is really something that I think the federal government is particularly well positioned to do. With that, I'd like to thank everyone who has been working on these programs, and of course, thank Senator Dole for his leadership, and happy to report the good news on the Working Healthy front.
Hey, thank you, Mark. Let me add that, this information is going to be nationwide, even though predominantly Kansans here today, but it's information that's going to be shared, and hopefully in any new national program, it's going to get some good ideas from our state and the state of Indiana and Missouri and all the other surrounding states. I'm going to introduce the rest of the panel, and first Jim Daig and Doug Schwartzentruber. I told him he wouldn't be a very good write-in candidate. That's a long name. But they're joining us today from Goshen Health System in Goshen, Indiana. And I've been there, and I visited their facilities and talked to a lot of the people. And I was impressed about how they were telling me that, well, they'll tell us that once a week at least, everybody on the team treating the patient gets together and they have a visit with the patient. I'll let these people tell you about that. But they're going to tell you about their programs, and Dr. Schwartzentruber had how many years at the National Cancer Institute? 8?
16.
16 years at the NCI, National Cancer Institute, so he knows what he's talking about. And after those two gentlemen, Bill Wing, and Bill is the Vice President of Healthy Services with Turner Corporation in Kansas City, and he's going to talk about technology and how the employees make better health care decisions, which is necessary. So, Jim, I guess you're up. You can either do it from there or you can do it from up here.
Guess we're going up there. Always follow my doctor.
You got to start first. Yeah, you're the boss.
Well, I'd like to thank you for inviting us here. We're humbled to be here. But I do have a little bit of a problem I wanted to resolve with you. Senator Dole is usually very quick. Well, he met me at our cancer celebration, and he met my wife, turned back to me, and said, you married up. I just want you to know the next day she left me, and she thinks you're right.
She'll come back.
We're privileged to be here, and let me first say that our role in this, we're presenting together because this is the style of what a community hospital does. So we hear a lot about partnerships with physicians and their organizational partnerships. This is an actual partnership. And so we do very little without the medical staff in our organization, and we feel that in partners that we have done a community benefit. So we're going to start kind of a step back with community. The community hospital lets you know that we're from Goshen, Indiana, which for today's purposes, are you advancing that or am I? For today's purposes, is outside South Bend. We are for Purdue University and whoever's playing Notre Dame that weekend. And for purposes today, it's not Goshen, Indiana. It's Goshen, Indiana, which, as you know, is Little Kansas. We're a 123-bed hospital in 1994. We are a disaster on behalf of our community. So starting with the theme that community hospitals have a responsibility to those communities, here's the kind of job we're doing. We got 3 weeks worth of cash on hand. We made $12,000 from operations last year. We have no debt capacity, which is a huge financial rating. So if we were to build and go to the bond market, we're paying top dollar. Also, age of plant is the same kind of criteria. We are in the fastest growing region in the state of Indiana, outside of those counties contiguous Indiana or Indianapolis, and no doctors accepting new patients. We have no managed care strategy, HMO, PPO, discounted, nothing. We're clearly not meeting community needs, and we're seeing 17% of our market share in the cancer area. And what we're doing with that market share is 83% of the people in our community are expressing their lack of confidence in our program by leaving to go someplace else. So what we've done is we put together a planning cycle, as most community hospitals in the country do, and we started with looking at what our community's needs. Simply stated, here's what we're providing, here's what the community needs, and they dovetailed on very few levels, hence the problems that we were seeing. Advance. Okay. So, out of our study process, from our physicians, came the desire to increase our services for cancer. So if we were a community, you get cancer in our community, all of you are participating in driving pools to people go to a larger center for radiation, for surgery, for chemo. And I go to church, go to the market. Every day I hear, when are we going to do something in Goshen? Because I'm sick of participating in these carpools. We put together the Center for Cancer Care in Goshen, Indiana. We're surrounded by other larger hospitals. And one of the questions that we were forced to ask is, why would you pass other larger hospitals 2, 3, 4 times as large to come to Goshen, Indiana for cancer care to a 100-bed hospital? The answer is because it's the best.
What I want to do in the next few slides is to share what our model of comprehensive, holistic, and integrative care is, and what makes us unique. And I'll share some practical examples, direct examples of how we meet those patients' needs, and then what others have said and how that is evaluated on a local and national level. Our program focuses on the patient and their family at the center of the circle, and I'm sorry, I don't have a pointer to guide your eyes, but we'll work from in out. We talk about being able to heal everybody because we can only cure about 60% of cancer. That healing happens not only with the traditional specialties of surgical oncology, radiation oncology, medical oncology, urologic oncology, but a variety of very key players, naturopathic physicians, counselors, dietitians, and our spiritual counselors as well. In that context of best people with a great facility to carry out our work, we practice innovative medicine and research, clinical trials that bring new options to patients with cancer. And what this team does, this entire team of people meets every week, like Senator Dole mentioned, to discuss every patient and include the patient in the decision-making process as well. So this is a system where we believe where the best communication can happen in a way that is free from the biases of our economic incentives as we have as physicians, and that'll come out in this talk a bit. All of our physicians are employed, are salaried by the hospital so that we don't have to compete amongst each other, which is common in many communities. And by the way, Goshen is 30,000 people, so this could happen anywhere across the country. 80% of cancer care is delivered in community hospitals. I want to share our mission because we are very mission-driven. Our mission is to provide the best cancer care available to our patients and their families. Our program is patient-focused, integrative, and comprehensive. Our innovative approach includes state-of-the-art technology and research provided by exceptional people doing exceptional work. And we read this mission before we have any of our multidisciplinary patient meetings. We read it at our business meetings. At every gathering, we hold this mission to heart. That keeps us focused, and it really puts patients at the center. We are driven by quality, not by profit. This high-value cancer care, then, is made possible by a multi-specialty that takes care to the next dimension. We provide integrative care, and it's just not integrating the medical providers, but it's also integrating our administrative team. That's why we're sharing the podium here, because we are integrated, and they've just delegated a member of the team to talk to the patient. That's perhaps me or the nurse, but we are a team. No one size fits all. We realize that we have very individual needs in patients. We try to eliminate incentive for unnecessary care. Patients are decision makers. They are the drivers. They are the ones that got the cancer center in our town just 9 years ago. This is a 9-year experiment, if you will, in Goshen, Indiana. They asked for a cancer center. We practice state-of-the-art technology. The 2 figures at the bottom are PET-CT. You know, we obtained a PET-CT. It's an expensive machine, but you can see the bright spots there. Those bright things are in the liver. That's cancer in the liver that after treatment with microspheres went away completely. And then on the right is a picture of tomotherapy, a very precise form of radiation that guides, it's an image-guided radiation delivery. This is high cost, but very high technology. This high technology is one of the keys that makes us different. We have what we call clinical thoroughbreds, a team of physicians that is very highly trained, all specialized in cancer. People that trained at the best institutions throughout the country. Some have PhDs. We also have a naturopathic physician that's done a cancer residency. Our surgery is done by surgical oncologists with specialty training in cancer surgery. Our medical oncologists have training in pain and palliative care. Some have PhDs. Some are inventors. Our breast surgeon, one of the ladies on the picture, is also trained in breast surgery, not just a general surgeon. The state-of-the-art technology we've hit on already. This particular unit at the bottom of the slide here is a robot, a Da Vinci robot for doing prostate cancer surgery. Clinical trials is also very important because we bring more options to patients. We give them opportunities to find cures through our clinical trials. And cancer is not growing in our community, but the numbers of patients are. And this is just a quick slide that tells the story since the Cancer Center opened in 1999. This is new cancer patients. I want to give you an example of a patient with prostate cancer. A urologist referred a patient to us, to our urologic oncologist, specifically to have robotic surgery. But our multidisciplinary approach decides that the treatment is really decided by a multidisciplinary input from our team. Our team, in this particular case, consists of a urologic oncologist, a radiation oncologist, a medical oncologist, a naturopathic physician, and other people that make up this team. Together, this team comes up with an answer, either surgery, radiation, chemotherapy, or active surveillance. In this case, a person that was referred specifically by one surgeon to another surgeon for an operation ended up getting radiation. And this is an example whereby that lack of a financial incentive, that lack of a motivation because this patient, having been treated by the surgeon who first saw him, would have impacted his paycheck, now could be treated really free from that bias of a financial incentive. And they got a treatment that was just very different from what they were referred for. How do we do then in terms of our outcomes? And when you look at the impact on our community of promoting screening, mammography that is, by educating the community, by advertising, you can see in that very first panel under stage 0, now we've doubled the number of women that were diagnosed with stage 0 breast cancer. That's the earliest stage, it's the most curable, but that's a result of our mammography. And again, state-of-the-art technology. We introduced digital mammography, the best form of imaging for the breast, and that has resulted in a significant impact. If you look to the far right, we still have women that come with stage 4, so our job is really not done. And as part of our education of the community for colonoscopy, the importance of early cancer detection, we actually went to the fairgrounds, our county fair, which is the second largest in the country, and we took a colossal colon. This is a colon you can walk through. And we had people crawling through this colon. I'm sorry. This was an anatomical display. And we promoted colonoscopies. We had a gastroenterologist there with a scope and saying, this is what I'm going to somehow use in your body to diagnose polyps. And you can see what happened. Our numbers of colonoscopy procedures went up, and on the right-hand side, we now detect earlier lesions. We detect these polyps before they become cancer. That has a huge impact not only on the quality of life, outcomes, but also on the cost. It's much cheaper to treat early on than later in cancer. And compared to national standards, either GHS, which is our hospital, or other hospitals in Indiana, or our American Cancer Society division, or all hospitals, we have learned that the type of results and outcomes are certainly very, very favorable. And I will move quickly. Honors and awards. We've received awards for our multidisciplinary model of care from the American College of Surgeons. We have patents that have resulted from this community hospital for inventions in radiation therapy. We've organized national meetings. And we've also taught our local community physicians, our non-oncologists, about cancer. Our patient satisfaction with this model of care is extremely high, according to Press-Ganey, which is a national ranking of quality care.
Could you just comment a minute about the naturopathic? Because I met the doctor and I didn't understand that was being done. So.
Naturopathic physicians go to school for 4 years, like we go to medical school, and are trained in Eastern medicines, other medicines that can complement what we do, and specialize in natural compounds. And we have a team of 10 physicians. 2 are naturopathic physicians, and they don't replace what we do, but they complement what we do and coordinate a lot of our care even after successful cancer treatment. Our cancer survivors now, there's about 12 million in this country, and we're living longer after cancer, and we need to know how to relate to those people. So.
Well, I think they mentioned something that reduced the risk of breast cancer by, what, 50%?
Many of the treatments they do have to do with improving the treatments, reducing side effects during cancer treatment, especially radiation side effects, maintaining nutritional support, etc.
Thank you. Next to me, Mr. Wayne.
Actually, we got a little bit more here if we could.
Oh, excuse me, Jim. All right.
Yeah, the other thing about the naturopath is so many people, there's a $1 billion industry in our country, use naturopathic techniques. Let's run them parallel to the traditional health medicine system, so if it doesn't work, we can bring them back into the traditional system. We're fleeting with time here. Well, I want to show you this slide and then move to recommendations. This is Goshen Health System today, and I'd like you in particular to take a look at the red and the yellow. And what this is total U.S. community hospitals, and obviously below break-even point. No margin, no mission in healthcare. Yellow is the category across the country in our size group, 199 to 100 beds. And the issue here is that community hospitals across the country are in trouble. I'm going to move forward through we're a magnet hospital, 3% of the hospitals in the country are. We've recruited 70 physicians, if you remember back to our opening community need, in the last 7 years. We have a 10-year plan because when Medicare goes belly up, we don't want to be part of it. Now, this is a program that we talked about in reaching out and doing a better job in wellness that has not been successful, and I bow to Claudia to bring you those kinds of points. And this is a book that Doug and I are writing. It's a book because we've made tons of mistakes at the community hospital level, but it's yielded what we would hope would be some healthcare reform issues. First, salaried physicians. Take the incentive out of it that doctors who have to earn a living on behalf of their families, salaried physicians. That will be very popular. Business incentives. As I talk to business leaders, they're not concerned with quality. They're concerned about their financial statements and removing the outlier cases, which in our particular area is heart and cancer. So early detection in these areas and proper prenatal care for mothers, particularly inner city mothers. And in our particular population, we have the 3rd largest concentration of Amish in the country, and so this is a problem that we see. There needs to be individual incentives for people to take care of wellness, because when we see advanced cardiac or advanced cancer disease, it has a lot bigger healthcare tag with it than it needs to be if we can do the earlier intervention. Got to make insurance companies part of this. This is part of the golden rule. He who holds the gold rules. We don't hold the gold. Insurance companies. How many small insurance headquarters have you seen? They'll love me for that. Medicare and Medicaid system. We have to stop, and please understand that the discount that hospitals across the country give to Medicare patients is 75% off of charges. For Medicaid patients, it's 82% off of charges. This is 40% of our business. Think of your business. Could you give these kinds of discounts and expect to turn a bottom line? What we do is cost shift it. And so if you are a paying patient or have private insurance, you're paying for a big part of Medicare and Medicaid. Insurance companies get us during our good years. We all know that the bulk of your health income is expended in your last days of life. So as soon as we turn 65, the insurance companies shed that risk pool onto the federal government. Something's got to change. Maybe they have to keep us for life in their risk pool. And then incentives for quality. Our quality is at the 95th percent level on all published data. That is doubling every year. The average in the state of Little Kansas is 68. So we feel like we're cutting edge. And the bulk of what we're saying is there's 40 community hospitals for every one major teaching hospital. Whatever healthcare legislation is going to happen has to consider the 40 community hospitals, because if they start going out of business, they're already stressed. Any legislation from the federal government will have trouble sustaining itself if local community resources are exhausted. Thank you for your time and attention. We bow to your questions, sir.
Yeah, we're going to do those after Bill.
Okay.
Oh, there's Bill. Bill. We're running a little behind, but we'll catch up. Right?
Senator Dole, thank you for the opportunity to participate with the Policy Forum on reforming healthcare. And it's a great honor to have the opportunity to share with you an experience that Cerner Corporation has with really engaging our employees around their healthcare. And, big question for me is, how do employers have the opportunity to really redefine how healthcare is delivered to the individuals in their community? And so what I'm going to do quickly is talk a little bit about how this aligns with Cerner's vision. Cerner is a healthcare IT company, so we kind of sit in the crossroads between how healthcare is delivered and how technology is brought to bear on that. We're also in a unique position in that we cover our employees and their families with healthcare insurance, and how do we align that with inside Cerner. Second, I want to quickly share a little bit about what our population looks like. Talk a little bit about the value proposition around connecting the individual. Third, or fourth, I should say, talk a little bit about our guiding principles, a number of strategies or initiatives that we've put in place, and finally, share with you what some of our results have been. So Cerner's vision is really depicted on the slide. I know it's difficult for those in the back. What you have here is really a community, and all aspects of a community depicted on this slide, whether that is a hospital, physician office, schools, homes, etc. And really surrounding this community is really the four tenets of Cerner's vision. So the first is, how do you begin to automate the different venues of care? So whether that's a hospital, a physician office, etc. Two is, as we automate the different venues of care across the community, how do you begin to connect the individual? And how do you begin to share their information across the community at the right time? And third, as we digitize healthcare, how do you actually take all of the clinical information and to basically structure and store it in a way that you can create knowledge? And lastly, how do you take that knowledge and drive it back into improving the healthcare outcomes, the financial outcomes, and the operational outcomes of the healthcare system? So what I'm going to do is talk a little bit about how we are using our employees. I mean, if you think about Kansas City, which is where we're based, there's 2 million population in the Kansas City market. And our associates and their families are in theory a microcosm of Kansas City. Happen to be that we represent about 11,000 lives, which represents 1% of the Kansas City market. But in total, we're 7,600 associates. 1,400 of those are global, so really talking about 6,200 here in the U.S. A little thing that is unique about our population, given that we are a healthcare IT company, the average age of our population is young, so 34 and a half, which creates the opportunity to really innovate and to really kind of have the opportunity to demonstrate different things around bringing kind of high-tech and high-touch together. The other thing I'll share with you is that today we spend about $32 million a year on healthcare. About $28 million of that is on medical, $4 million of that is on pharmaceutical. And our trend over the last 5+ years, since 2002, is averaged 5%. So about half of what it has been nationally. Now, our young demographic is one of the contributing factors, but we believe that some of the strategies that I'll share with you today have driven a number of those trends. So we really believe that by redefining the healthcare experience for our associates, we can create more connected and engaged consumers and providers. We believe we have the opportunity to improve their health status, and we believe we have the opportunity to generate savings. So we spend $2 trillion a year on healthcare today. 31 cents of every healthcare dollar goes to administration. $600 billion. So our goal is really, how do you redefine the healthcare experience on behalf of the individual? And two, how do you begin to remove friction in the healthcare process? And how do we spend less on administration? So as we looked at a number of strategies that we've deployed within our population, these were kind of our guiding principles. So first of all, how do we create a very person-centric experience? How do we put the individual back into the center of their care? And how do we create transparency, both on the clinical side of the equation as well as on the financial side of the equation? Two is, how do we create a system that is provider-friendly in order to engage them differently? Third, how do we remove friction? How do we leverage the evidence? How do we leverage technology? And ultimately, how do we create a new consumer experience? So we've deployed 7 strategies inside of Cerner, really focused on creating an integrated experience. And it starts with benefit plan design, and it aligns itself to the care delivery system, and ultimately how we incentivize and reimburse providers. So from a benefit standpoint, the first thing that we did, and this started almost 4 years ago, is that we wanted to create financial transparency. So we've been down the road of consumer-driven health plans. We do not have a health savings account, but we do have a health reimbursement account. And over a 4-year period, we have migrated 100% of our population into a consumer-driven health plan design. Started with 48% adoption in the first year while they have choice of a PPO and HMO design. That migrated to 72% and then went to 100% where we sit today. The other thing that we've done is really try to align our benefit plan structure to how we want care delivery and how do we create the value based on the evidence throughout that process. And I won't go into the details today. The second one is we've actually leveraged a card, we call it our Healthy Card, which is up here on the screen, which is a multi-purpose card. So this is my health plan ID card. What's unique is that mag stripe on the back of the card. It's a 3-track mag stripe, and the third track on that is actually for healthcare. So encoded on that card is my demographics, my benefit plan design information, and I have the ability to leverage that card for a number of things. So the third one here is that we are providing what we're calling a healthy record, a personal health record, to all of our associates and their families that is pre-populated from claims data, from pharmacy data, from personally entered data. We're beginning to work with some of the hospitals in the Kansas City market to bring in the clinical data. And when you swipe this card, it will actually launch that record in their office and provide that information to them. Fourth is that we believe, again, that you got to bring high tech and high touch together. And so we've started a service called our Healthy Advisor Service, really focused around wellness, engaging our associates around what their current health status is, what should be the goals and recommendations on how they should improve it, and how do we begin to track that over time with the right incentives in place. The fifth one is actually really focused on those who have a chronic illness. I heard you, Chris, mention, or somebody mention, diabetes. And that basically, how do I help the diabetic in a way that's both high-tech and high-touch around setting a care plan, monitoring that care plan through the course of their life. The fifth and sixth one are really focused on how do we bring care right to the employer's campus through both a pharmacy and a clinic that's got primary care, lab, pharmacy, physical therapy, and chiropractic services, really focused on creating a medical home that is accessible on our campus. We spend more time at work than anywhere else in our life, and we felt that it was important to create that access, create the affordability. One of the things we did here was actually waive the copay and coinsurance if you use the clinic as your medical home. And so really we have the opportunity to help coordinate their care and deliver medications right there on site. This slide here, I know you probably can't read it in the back, just goes through a number of our results. I'm not going to share all these specifically with you. Suffice it to say, we really are focused on wellness, prevention, primary care, and the whole person from a chronic illness standpoint. And we've had these services in place, most of them, for going on 2.5 years. This actually happens to be the second year results, 2007, and we've saved our health plan just over $3 million through the collective strategies that we shared earlier, starting one with health plan administration, two with really a focus around coordinating care between the specialist, the outpatient, hospital, and ER, third around pharmacy, and lastly, since the clinic and pharmacy are right on our campus, we basically guarantee to our associates and their families, you can be in and out in 30 minutes with your prescription. That journey will typically take about 3.5 hours, and we are basically saying we want to give that time back to you. We want to create the accessibility, we want to create the affordability, and ultimately we want to coordinate the care on behalf of our individuals. So in closing, what I would basically say is that we are very strong components that employers have a key role in how healthcare gets delivered here in the United States. Two, that we believe that information is key. The ability to aggregate data and share it across the community on behalf of an individual is part of that. But third, we also believe that you got to leverage both wellness and condition management in order to basically help with both the high-touch side of this equation in providing better care and coordinating it across the community. Thank you.
Now that we're going to have a few questions this panel, and we're going to have a 15-minute break. And you know, we have boxed lunches available for everyone here in the back of the room. So if you haven't had lunch, well, I don't know, thank the chancellor, I guess, or somebody. But in any event, then we'll come back and get into the second panel. And Chris, do you want to lead off with the first question?
Sure. Thank you all four of you for extraordinary presentations. Marcy, I just wanted to ask you a little bit, you know, some of the really, I think, creative work that you're doing is on the use of, can you hear me?
Need a little more volume on...
Does that work? Yes. Okay. Some of the creative work that you've been doing is the use of these care coordinators, these other people to help people navigate through a very complicated healthcare system, empowering them to know where to go, when to go, etc. Can you tell us a little bit more how that works and that any implications you might suggest that it has for federal policy and coordinating between Medicare and Medicaid?
Mm-hmm. Yeah, the benefit specialist that we have in Kansas is really unique to our state, and I would want to give credit to Mary Ellen for designing a model where care coordination is really the key. The way in which the benefit specialists help individuals is really around the... Can you hear me? Oh, sorry. Is really around the benefits themselves. Thinking about the trade-offs that someone has to make when they're trying to put together this whole person package, trying to figure out how essentially they can stay employed and keep enough benefits to take care of themselves and their families. I think where the benefit specialists sort of stop, and my recommendations, and I think the recommendations of the Health Policy Authority begin, is advancing this notion of a medical home. That care coordination piece is just critical. If you think about all of the administrative costs that are essentially wasted because we have duplicate tests, we underutilize health information technology. We don't have information at a physician's fingertips when they're trying to treat us. So I think expanding that benefit specialist model to incorporate this medical home coordination of care, really using evidence-based medicine to advance that in a way that the provider knows what they ought to be doing, but they're really sharing that responsibility with the individual who is also directing their own care.
Thank you very much.
Just quickly, are there other states that are adopting this program or have similar programs?
There are 32 states that have Medicaid buy-in. We are the only state that has these benefit specialists.
So you're the pioneer, right? I want to ask either Jim or the doctor, when I was in Goshen, I was impressed with the people I talked to, and I met a lot of the patients and how satisfied they were and how, they felt early detection and all the things they do, and particularly this, which it may not be new, everybody may know it but me, but the fact that once a week, they would all talk about patient A. So everybody with a nutritionist up to the oncologist would take that case and sit down and review it. Is that unique, or is that pretty widespread?
I would say that many medical institutions do have multidisciplinary conferences, which in many instances involve physicians. But I think what is unique about our program that it involves all care providers. So there's the whole gamut of providers, from people that are involved with discharge planning, people that are involved with rehab services, people that are involved with hospice, people that are involved with your spiritual needs, your dietary needs, and we get everybody in the room at once. It's kind of a challenge because of people's times to do that, and you have many opinions, but on the other hand, that is the one venue where we can really meet that patient's needs best, because everybody has a voice.
Oh, plus the patient doesn't have to make 8 or 9 stops, right?
The patient would visit these providers in our one building. That's the other uniqueness, is that there is one venue under one roof for all the specialists, as opposed to having to go across the city or out of town to visit the specialist.
And I think just quickly going back to the point Marcia made on what's called care coordinators, that's the one recommendation, or one of the recommendations we made with our commission on VA healthcare. One of the young men on our panel lost his arm in Iraq, Jose Ramos, and he'd had so many caseworkers he couldn't remember their names, which seemed to me to be not a very efficient way, and it certainly wasn't going to help the patient. So one of the recommendations has been that if you're seriously wounded, when you walk into Walter Reed Hospital, you're assigned a care coordinator who stays with you until you go home or back to your outfit or wherever. And we think, even though it's not going to cost a lot of money, it's not a big program, but it makes a lot of sense. And they'll take care of getting appointments and working with the family, and it's just, well, you were there first, so you know how much it means to not only the patient, but the family.
Senator Bill, I wanted to ask you a question, too, about, the programs you have are remarkable, and I wanted to talk to you or ask you questions about where you think the limitations are. For example, if you're trying to, as big as you are, it's hard to use market share to change everything, I assume. And how does that, do you think there needs to be better coordination with Medicare or Medicaid, or incentives for people to utilize technology like e-prescribing, electronic medical records, to help making sure that wherever your patients go, there is some linkage?
Absolutely. There's not only the core of this is really being able to have access to the data, which means that you need a methodology for collecting that information. But even once you have it and it's within the 4 walls of your organization, the real question then is, how do you begin to share that as well across the community? Because ultimately that information needs to move. So, one, we believe that absolutely you got to have it as part of the different venues of care. But 2, then you've got to figure out how you can move that data with the individual, share it across the community, and leverage it as part of the delivery of care for that individual.
Yeah, you talked about, I think it was health coaches.
Yes.
That's not like a lobbyist, is it?
No, it's not.
Because lobbyists seem to have a bad name these days, so I don't use it anymore. I use the word advocate, and people like that. But like a health coach would come to Lawrence, for example.
So we have kind of two sets of services, one on the wellness side, one on the chronic illness side. So the coaches are focused on chronic illness, diabetes, congestive heart failure, et cetera. Some of it could be face-to-face, some of it can be done virtual. And so a lot of it can be done virtual, but really interacting with the individual, much like their advocate, helping them understand, one, the condition that they have, what is their role in the process, coordinating their care, but ultimately helping them understand what's most important along their care plan and ensuring that those things get taken place.
But it's not tilted to favor one company or one policy, or in other words, it's...
No, it's really centered around the individual, tailored to their needs in conjunction with their provider.
Chris?
Jim, I wanted to ask you a question about you. I thought your remarks about aligning incentives is really important about if we want to modernize the delivery system. And there's been a big debate in Washington. And by the way, I don't know if we can get everyone on salary, but you can. Thanks for that recommendation. We'll bring it back. But I wanted to ask you that there's another big debate going on in Washington about physician-owned hospitals, outpatient clinics, et cetera, and some concerns have been raised by hospitals, community hospitals in particular, about what impact that has on healthcare delivery and also in just in terms of misaligned incentives. And I'm wondering if you could comment on that a little bit.
I don't know anything about it, but I could do about 20 minutes. No. The theme is a little less. The theme is we're in a free marketplace. A doctor is incurring the same kinds of expense cuts from Medicare and Medicaid reimbursement as our hospitals. As they struggle in a free marketplace to maintain their standard of living, surgery centers, imaging centers, GI centers, all these centers open up so that the technical fee used to come to the hospital now goes to the physician. Problem is, and this risks of any generalization, that generally speaking, the payer groups seem to be better at the outlying centers, which leaves the bulk of the poorer paying groups, Medicare, Medicaid, for the hospital, consequently pulling the cream off the top and driving the costs up for healthcare in any individual community. There's facts in that and studies of that around the country. It's hard to justify these kinds of centers when they're duplicating work and taking dollars out of the healthcare system that we would use then to plow back in to give free care, to give charity care, and continue to meet our community missions.
I think I should have asked Barbara this question. They're still using telemedicine a lot out in western Kansas?
Yeah, we
Because
reimburse.
we were talking again on the way out about how it kind of started off and then maybe faded a little bit. Is it starting to bloom again?
The KU telemedicine program is a terrific one. It continues to grow and expand, and we now reimburse for telemedicine services in Medicaid with the state employee health plan. And I know that there's been a push actually to mandate that all private health insurance covers telemedicine services. Mandates don't always go far in Kansas, but I think recognizing the value of telemedicine is certainly something we have in Kansas.
So it's available in how many counties? Probably most of them.
70.
70
Dave Cook says 70, so that's what we're sticking with. He's the former director of telemedicine. 105.
Yeah, that's good. Yeah, and I remember watching, I went over to Hayes, Kansas, one of the metropolitan areas, compared to Russell, and you were demonstrating how it worked. This is when it just started, and it seemed like, boy, this is great for where you can't find the doctor in some of these small communities, or you have one doctor who covers several communities, and here's a way to communicate with the, people across the board. Yeah.
It really does work really well. It started in Hayes, and Hayes is one of the places where we still do the most. It's particularly good for children because children relate to televisions well and doctors on televisions well. It's very good if the patient is seen one time, a cancer patient, for instance, at our medical center, then goes home and is followed at home, but the cancer specialist can actually also visit with them.
Less expensive, too. I mean,
Much less expensive. Time-wise and actual cost-wise, much less expensive. A very good way to provide care.
Good. I must have seen the original. Now we're going to have a 15-minute break, and again, we have box lunches